be talking about open spinal cord procedures for pain. I'm filling in for Bill Rosenberg, so anybody that's heard Bill speak about this, it's going to be tough to top that. Next slide. Here are my disclosures. None particularly relate to this topic. Next slide. So when do we talk about destructive techniques for pain? In the vast majority of cases, these are in people that have cancer pain, and they've generally failed conservative modalities. I think what's important to know is we hear so much about pain therapies, and we often forget that neurosurgeons are actually, you know, the founding fathers and mothers of pain surgery. And, you know, so we have some tools in our armamentarium that aren't awfully commonly used, but that we all should be aware of, and that we should make our oncology teams be aware of. You can do this on all levels of the pain pathway. Next. So when we're talking about, you know, anytime you have pain, say you have pain in your thumb, you can have a problem with the receptors at the tip of your thumb, all the way up your arm, all the way to your cervical, spinal cord, into the brain. And so when we talk about stimulating and, or in this case, ablating regions, we can tackle any of those areas. You know, so if we start at the bottom of the slide, we're looking at neurectomy, or thinking about rhizotomy at the dorsal root. Of course, there's ganglionectomy, DRES, cordotomy, for the very brave, mesencephalic tractotomy. Today, I'm going to focus on cordotomy, myelotomy, and dresotomy, all in the next 10 minutes. Next slide.
Sorry.
Next slide.
I'm sorry, the slides are not showing.
I can't see it. Vibor?
Yeah, I'm sharing the slides. Let me try one more time.
Okay, I don't see them on my end, but I thought it was me. Oh, there they are.
Are they showing now?
Yeah.
Sorry about that.
No problem. So basically, you know, there was nothing to be missed other than, you know, pictures of things we all know in terms of nerves, dorsal roots, etc. So here are the sensory pathways. In general, we talk now about the medial and lateral pathways. This is, you know, somewhat of the dorsal columns and the spinothalamic tract, but we're also talking about how things are processed. So the lateral pathway is generally thought to involve sensation, with the medial pathway involving emotion. Next slide. So originally when cordotomy was offered, believe it or not, you know, this was open and was quite an aggressive operation. So, you know, 2 to 3 ligaments of the dentate would be released. There would be rotation of the spinal cord, and you would make an incision of 4 to 5 millimeters anterior to the dentate ligament. You know, I recently presented a slide deck at the pain section meeting, which is now in combination with the spine section. So keep a lookout for that next year. And only one person in the audience had any experience with doing this open, and it was actually kind of a patient request. Patient did well. Next slide. Next. Oh, so in terms of complications, you know, I think if you're studying for your boards, people always talk about Odine's curse, you know, which is failed respirations, and that's, you know, the textbook answer is you do a bilateral cordotomy and this may happen. In reality, well, I think most of the time people don't do bilateral cordotomy, so there are certainly people that do. Bill Rosenberg has done several. but this is highly uncommon to see. Much more common, you're going to see occasionally Horner's syndrome and some dysesthesias. Mirror pain also is something more frequent. And then I think these mortality rates are probably overstated in terms of, you know, these are performed on very sick people. So, you know, a lot of these people would have passed with or without intervention. Next slide. So percutaneous cordotomy, which is what we talk about doing now, was actually first described in 1963, and this was done with fluoroscopy and myelograms, and so, you know, very brave in the pre-CT era. Next slide. Who are candidates? Generally, these are patients with intractable unilateral somatic pain, so not pain in the viscera, from malignancy with a life expectancy of less than 1 year. Mesothelioma, Pancoast tumor, lower extremity cancers are the most common. People that have bilateral pain, midline pain, or pain above the dermatome of C5 are likely not candidates. Here's some numbers you probably haven't thought about in a very long time, but you know, those are pulmonary function tests and some values that are safest just because of the nearness of the respiratory drive. Next slide. So in terms of doing this, for those of you that have done or seen a high tap, sometimes they'll do these in kids. This is a very similar approach. You're going to do a myelogram either through that tap or through a lower tap, 20 to 30 minutes preceding the operation. From the patient's supine, most of these are performed in CAT scan, an important fact I didn't mention. Head is flexed and fixed. 2 millimeter CT is obtained. You're going to do IV anesthesia, and most commonly, if not always, this is an RF ablation. Next slide. So the needle entry, you know, is read any paper about this topic or, you know, anything about getting a tap in that area. It's near the mastoid tip. You're going to go on a vertical plane perpendicular to the spinal area, anterior lateral portion of the spinal canal, and you're going to go very slowly, advance and adjust and scan after each move of the needle. Ideally, the needle is 2 to 3 millimeters anterior to the dentate. Next slide. So here is what the picture looks like in CAT scan. Next slide. And then what you do when you're there is basically you want to test impedances. So these are common impedances in spinal fluid versus the spinal canal. And then you gradually start increasing stimulation. You're looking for a motor response and or pain, paresthesia, or warmth at the target that you're trying to hit. Next slide. You're going to make a test lesion first. You know, these are standard kind of parameters in terms of RF therapies where you're doing, you know, one smaller lesion and making sure that that goes without incidence before doing a longer and hotter burn in that area. And you want to make sure that you're iteratively checking your patient for their sensation and their motor strength. Next slide. So Campilot is well known for cordotomy and his ablative work. This is the largest series. He had 207 patients. 12 of these were bilateral, initial pain relief, and 92 and a half. So here you can see his issue is permanent dysesthesias and slight weakness, most common. Next slide. So myelotomy. And myelotomy is another procedure that was at one point done open and now is most often done through a small approach. There are people that do this essentially percutaneously, again, with imaging. The majority of people I've spoken to and know that do this with, you know, a one level laminectomy and do a punctate myelotomy. Next slide. Next slide, please. So this, again, you know, back in the day, things were very aggressive. And so here you're seeing what a full myelotomy looked like at the time. And, you know, the general indication for this is for visceral pain and midline pain, though our images do not quite look like this any longer. Next slide. So what's absolutely essential when you're doing a myelotomy is to identify the midline. The key thing here is that the central vein isn't always in the midline. So the best marker of this is doing, looking for the dorsal root entry zones bilaterally and identifying the midline based on the midpoint between the dresses. You can use monitoring as well to help you know that you're in the right spot. And here you're going to gradually advance the blade. This goes to a depth of 5 or 5.5 millimeters, and there's a gritty feel at the base of this. And this is pretty consistent with how deep everybody says you should go. And next slide. A couple of series of patients. Ashwin Viswanathan has one of the more recent ones, and you see that 8 out of 11 people have had good to excellent pain relief. Of note, there were new motor deficits. 2 out of 3 of these were transient. Next slide. And these, again, are patients that are in extremis. So it's important to keep in mind that oftentimes, you know, when you talk to people that have had these deficits that sound horrific because they're new neurologic deficits, the patients are so happy to be out of pain that, you know, and this doesn't always hold true, but, you know, they're willing to accept some of these deficits. Some of the other complications, you know, these are sick patients, so things that you would expect, DVT, pulmonary edema. Next slide. So again, you know, this is for limited myelotomy. What's neat about this is it not only relieves the somatic pain, but it also relieves visceral pain. So this can be highly useful in people with abdominal and pelvic cancers. Next slide. Why is that? Well, you know, I think our understanding of the viscera, like think about when we try to, you know, control visceral pain with spinal cord stim. It's oftentimes ineffective. We're not sure where the levels are. And, you know, so, you know, some work's been done with pancreatitis, et cetera, with SCS, and there's mixed results, so somewhat promising. So here, you know, I think that we can't say for sure what the exact innervation is, and it's very complicated because so many of the ganglia innervate the viscera. But suffice to say, even a small punctate myelotomy relieves a lot of visceral pain. Next slide. Next slide. This is the difference between this punctate myelotomy. Again, you're just making this super small incision in the cord as seen on the right hand of the slide versus the commissural myelotomy, which was done in the past, which was the multi-level laminectomy, where you would go up and down the spinal cord. And the results with what Nada has described for this midline punctate myelotomy and that Viswanathan has done seem to measure it with the commissural myelotomy. Next slide. In terms of where you make the lesion, so if it's abdominal viscera, the consensus seems to be T3, T4, pelvic viscera, T6, T8. And, you know, this is a little bit, there aren't that many studies or data points, but this is a helpful chart if you ever do need to figure out which level to attack with the myelotomy. Next slide. Next slide. This is a picture looking at that DRES. So here's an example of the central vein not being on the midline, and measuring from the DRES as to where the effects are. And again, you know, you can stimulate with a probe here and see where your sensory fibers are and know where the safe spot is. Next slide. In terms of lesioning, so, you know, the people do different things. And, you know, I think in general for the commissural myelotomy and a lot of people that I talk to, generally this is, you can use a knife. You can also use a radio frequency probe, but you know, you can use like a beaver blade or something similar, or just an angiocast type needle. Next slide. And so this is actually, you know, the needle that Burchell shows in his book. Next slide. Next slide. Again, you know, everything is small series in this. The pain section is actually trying to put together a review of cordotomy and myelotomy currently, you know, just to give some guidelines as to what good practice is and where different outcomes are. Next slide. A little bit about DRES. So, you know, again, this is a lesion of the dorsal root entry zone. Next slide. First described in 72. This is usually for unilateral pain relief. Most commonly, you'll talk about this for arm pain. You know, again, the board question is the brachial plexus avulsion, but you can use it in other situations as well. Next slide. And here, you know, again, you're going to look for where the nerve roots are exiting or where they're coming out of the dorsal root entry zone. And I think actually the picture on the left, the cartoon, helps you see where you should be making these lesions right there at the DRES. And you're going to do a series of lesions up and down. And this is one of these things because, again, you know, there's some overlap of dermatomes where, as opposed to the punctate myelotomy, you're going to go over several levels. Next slide. Again, you can do this in a couple of different ways. You can do this with sharp dissection. You can do this with radio frequency. Nash Schold had, you know, a special needle that has a curve on it, you know, so it's essentially like a right angle curve. And so that's one thing you can use. And depending on what RF system you have, you can do it that way. Again, I've also seen people do it with the bipolar and or the knife. Next slide. How deep should the lesion go? So there's anywhere from 2 to 6 here. Next slide. Next slide. So I think I knew that one was coming up, which was the deeper one. And, you know, when you look at results, it seems like the results are, most people will do the 2 millimeter. You know, when I presented this, Konstantin Slavin, actually, when he trained in Russia, was on the study which had the best results. And they go a little bit deeper, but in the audience, everybody generally recommended 2 to 3, other than Konstantin, who goes a little bit deeper. Next slide. So indications: avulsion of brachial and lumbar plexus, pain after spinal cord injury, less commonly pain with spasticity, malignancy, pain after a peripheral nerve lesion. Next slide. Complications: prepare your patient that they are likely going to have some motor weakness when they wake up. This is usually transient, and you know, oftentimes you're going to start steroids after this procedure. There can be sensory loss, and of course, with any pain procedure, we can cause more pain. Next slide. So in conclusion, we have these tools in our armamentarium. Consider them after exhausting other less invasive modalities. patient selection is crucial. There's a number of pain neurosurgeons across the country that are doing these. I wouldn't say regularly, but more commonly than others. And so keep in mind that if you want to do these, you should go someplace that does several or has done several, so you can get training in that area. And I think that's all I have.
Thank you, Dr. Palitsis. This was a very nice presentation. Thank you for filling in. So,
Oh, my pleasure.
I have a quick question. So how do you see this in terms of the overall approach to a patient in relation to, say, intrathecal pumps?
Yeah, I think that it's I think it's a hard question, and I think there are a number of patients that can do well with pumps. In terms of doing pumps well, you have to make sure that you have somebody that is going to be very aggressive about turning up the dose and managing this and making sure this is part of the patient's is adequately treating their pain. I've seen this done a couple of different ways, and there's places that are very good and very bad at it. Sometimes pumps, however, don't work for all patients' pain. And, I think in cases of visceral pain, sometimes that can be really hard to control with a pump. So myelotomy isn't uncommonly used. And then there's some other issues with pumps in terms of people that are getting chemotherapy or at super high infection rates. At least in these procedures, you're not putting in an implantable device.
Got it. Thank you. All right. Any other question we have in the meantime?
Sorry, I actually had a question. How do you choose between myelotomy versus cordotomy?
I'm sorry, how do I choose between a myelotomy and
A cordotomy?
Yeah, so, I think, so a myelotomy, you're most commonly going to do for abdominal and pelvic pain that's bilateral or visceral pain.
Okay. So if I had
sometimes you can do, yeah, go ahead.
So if I had a patient who had unilateral pelvic pain from cancer, then you'd lean towards a cordotomy?
That's a great question. I think if it's pelvic visceral pain, even if it's unilateral, I would probably go for a myelotomy. Usually a cordotomy does better with like somatic type pain as opposed to visceral.
Okay. And then I had one more question. In terms of levels, I saw that you pointed out the myelotomy levels being like T6 to 8 for something like pelvic pain. Is it the same for something like for the cordotomy, or is it? I thought it was a little bit higher, and I'm not sure.
Yeah. So for a cordotomy, most people do a cervical cordotomy. So if you flip back on the slides, you can see where that's usually between C1 and C2.
Mm-hmm. Okay. Thank you.
My pleasure.
All right. So we'll get started with Dr. Gerard, who will be talking to us about the stereotactic radiosurgery. Are you guys able to see the slides?
I can see them.
Great. Okay.
All right, we'll get started. So again, I'm going to talk about lesioning techniques. So we're going to talk in this section about using stereotactic radiosurgery as a form of making functional lesions. Next slide. So again, even though we're talking about some novel techniques and procedures, it's important that we realize that there really is nothing new under the sun, that many of these procedures and at least the underlying fundamentals have been around for quite some time. This is just an example of Spiegel and Weiss's stereotactic setup here. Next slide. And then again, this 1951 was Lars Lexell, first radiosurgery and capsulotomy was published in 1953, not long after that first stereotactic apparatus. And this is just a picture here of him with one of the prototypes. Next slide. So, these stereotactic ablative procedures have been around for several decades. Again, you had Spiegel and Weiss's first reporting thalamotomy for tremor in the late 40s, and then shortly thereafter, Lexell and Telerak developed stereotactic techniques and described the anterior capsulotomy. With the goal here of the capsulotomy being in the anterior limb of the internal capsule, to disrupt connections between prefrontal cortex and basal ganglia in patients typically with obsessive compulsive disorder. Next slide. So I'm really gonna focus a little bit in on essentially 3 techniques. Most of my experience, the vast majority of it's come using the gamma knife. I will talk about the linear accelerator as well and some of the data for that. But again, most of my experience has come using the gamma knife setup. We'll talk about trigeminal neuralgia and using stereotactic radiosurgery to do lesions in the trigeminal nerve for treatment of trigeminal neuralgia. As far as for using the gamma knife, the publications support its efficacy and superior and safety profile have been around for quite some time. I think you're seeing increasing support for use of linear accelerator in this as well. In tremor, we'll talk about gamma knife thalamotomy. It's been described mostly using the gamma knife. Its efficacy and safety have been well supported, and there's a couple head-to-head comparing gamma knife thalamotomy with deep brain stimulation. The outcomes tend to be inferior with the gamma knife thalamotomy compared to DBS, but again, it's a good option for patients who are not good surgical candidates. And then into a little bit on psychiatric diseases. Before I forget, thanks to Samir Sheth for giving me some access to some of his slides on this particular setup and what we've learned as far as doing anterior capsulotomies. Next slide. So in trigeminal neuralgia, it's important that we establish sort of the language that we're going to speak because there's a lot of different publications that are out on this. It's a very common pain syndrome, and depending on what scale people use or how they describe their results, it can be difficult to understand, and sometimes we're comparing apples with apples, and sometimes we're comparing apples with oranges. So just most of the time, people will talk about the linear visual analog scale, which is the top of the left, or you can use the faces analog scale on the bottom on the left. It's just important that whatever you decide to use, if you're going to be tracking patients, that you're consistent. And then most people now use the BNI, or the Barrow Neuro Institute pain score on the right side of the screen. And so a lot of times when people describe, they say the patient had a good outcome, and you say, what does that mean? Sometimes they'll be talking about pain score class 1 to pain score class 3A on the BNI scale, and sometimes they'll include score 3B. And the difference there is, the 3B patients have some pain, and they have pain and they're taking medications, but they describe that pain as an acceptable level. But there's a big distinction between those two. Next slide. So I think the first step whenever evaluating patients with trigeminal neuralgia, I see several patients that come with that label each week, and maybe see 10 or 15 of them, and none of them have the same story. None of them have the same pain. And it's important to really recognize that trigeminal neuralgia or face pain is really a spectrum. It's not a single entity. I think Dr. Birchall has done a fantastic job of helping tease this apart. I put actually the website to his questionnaire. It's a great place to go look for reference. It's actually an online questionnaire. You can click the answers. You can make up answers if you want. And the website will tell you what it thinks the type of pain that you have, whether it's TN1, TN2, or other types of neuropathic pain that based on the answers to the questionnaire. We've actually designed our own questionnaire, but it was based largely on what Dr. Birchall's published in terms of work in this subject. There's many different treatment options that are available, ranging from microvascular decompression, which we're all familiar with, percutaneous procedures, different types of rhizotomy, glycerol rhizotomy, RF rhizotomy, and then stereotactic radiosurgery, which we'll focus on today, and nerve blocks as well. And then, of course, there's a myriad of patient attributes to really consider when you're going to be selecting their therapy, ranging from age, medical comorbidities, to even sometimes patients have their own set risk tolerance, or may already have hearing loss in the ear and the contralateral side, which all has to be taken into consideration. And then this bottom part I'll keep up probably for the next couple of slides, but there have been some well-identified predictors, regardless of treatment technique that's used, in regards to outcomes. Everybody is aware that TN1 patients have better outcome than TN2 patients. So that's an important consideration. There's been some good work, again, a lot of it led by Dr. Birchall's group, about grading the degree of neurovascular conflict, and shown that especially with MVDs, that patients with grade 2 or higher, meaning that there's more than just contact with the nerve, do have better outcomes. And of course, the age of the patient and the duration of the pain have an impact. And something that's important to consider when we talk about comparing these studies is, if you think about patient selection in general, older patients are going to get selected for things like Gamma knife or stereotactic radiosurgery, and yet we already know that the older the patient is, the less likely they are to have a good outcome. And so remember that you're tainting the data with your own patient selection. Next slide. They also tend to have longer pain relief. So, the first thing to go to as far as the next step is where exactly does stereotactic radiosurgery fit into the treatment algorithm for trigeminal neuralgia. I mean, certainly microvascular decompressions, MVDs, is well positioned, as a go-to surgery for patients or young patients who have TN1 and neurovascular compression on their imaging. It has the highest BNI grade 1 outcomes. It has the longest durability in general in the literature. This is pretty well established. It has typical risks of a PFOS craniotomy or craniectomy, things like CSF leak, hearing loss, facial numbness, where to consider when you're considering for these patients. But certainly anybody under the age of 65 should be considered. Certainly you can go older than that, depending on the how healthy the patient is. It's certainly done on patients that are older than that. There's been publications about doing MVDs on older patients. And then percutaneous procedures, again, factors to consider. TN1 again does better than TN2, which is not too surprising. The percutaneous procedures have a very high rate of immediate pain control, which can be very helpful, especially if someone's in TN pain crisis. They're admitted to the hospital. They're on IV pain medicine that they can't seem to get off of. This gives immediate relief. Risks are lower, mainly facial dysesthesia, although anesthesia dolorosa and numbness are also reported. Very rarely you can have injuries from the needle going someplace that you don't want it to go, but it's extremely rare. As far as SRS, similar results as far as TN1 better than TN2. It tends to be used in older patients or patients who've already had an MVD and failed it. It does have a 70 to 80% pain control rate in general in the literature, but it's a delayed response. The average response time is about a month, so it's not very useful for someone who's in a TN pain crisis in general. There's been recent reports that the durability of gamma knife or stereotactic radiosurgery for trigeminal neuralgia may be longer than originally published. There's been some reports of 50% at 8 to 10 years. And then there's been actually a couple reports that show 60% pain control at 8 to 10 years using higher doses, which we'll talk a little about in a minute. And the risks here really are dysesthesias. You can get numbness in the face as well. Bothersome numbness is less common in stereotactic radiosurgery than with the percutaneous procedures, and anesthesia dolorosa is also less common with SRS than it is with percutaneous procedures. Another thing that's important to point out, which some publications are advocating for, is that there's been studies showing that if you do an MVD after patients had SRS, that there's no increased risks. It's not like there's a lot of scarring or it's difficult to access the space if the patient has an MVD that's been done after gamma knife, after stereotactic radiosurgery. And again, I keep these same outcome predictors on the bottom because they're the same for all of these. Next slide.
So, Dr. Jared, I want to remind you that we have less than 10 minutes for the presentation so that we stay on time.
Yep. So, I think it fits in. MVD is still your first choice in younger patients, but bear in mind there's no increased risk. There's been some people that have advocated actually in the literature for doing in very young patients, maybe starting with stereotactic radiosurgery. In the end, so we'll look a bit about survival curves, and most people who fail, the curve gets flat at about 8 years. So if they fail, they're still plenty young enough to have an MVD, because the concern in the past has always been that the patients are outside the window. TN2, other pain types, there's good publications on using it for MS. The outcomes are not as good, but they're not as good for any of these procedures, and so it's nice to have something with a lower risk profile. Next slide. This is just an example of targeting. Using the gamma knife, you can do without any block sectors or with block sectors, depending on how you want to shape your dose curve around the brainstem and other close structures. Something that is, I think, becoming increasingly recognized is that there can be a big difference in the pain relief with doses, but there's also an increase in side effects. And also target location. So traditionally, we use the root entry zone as the target, which made it difficult to get the dose he wanted and stay away from the brainstem. But there's been several reports now showing no difference in outcomes between more distal on the nerve versus right at the rudimentary zone. The nice thing about moving a little more distal on the nerve is it allows you to get a higher dose, which has been shown to have better pain control. Next slide. An example of targeting using a Linux system. The main difference here is the shape of the collimator is different, and the way that the dose is designed is different. So some people will say 90 gray, but they're doing it to a single point that's the 100% line, whereas others will say 70 or 75 gray, but it's a 90% isodose line. Next slide. And again, this is a retreat. So this is patients who've already been treated and failed, and then they're retreated with gamma knife versus microvascular decompression, and the survival curves are similar. There's some data to suggest that MVD is a little bit superior, but the whole real point of these is to show that after 3 or 4 years, the curves get pretty flat. Next slide. Moving on to essential tremor, it is the most common movement disorder. It's very prevalent, especially in patients over the age of 60. And taking care of these patients, you see just how significantly it impacts their activities of daily living. And for these patients, medical therapies can sometimes be very limited. They're different from our Parkinson's patients in the sense that a medication response doesn't really give you any insights into how they're going to respond to surgical therapies. This therapy tends to work well regardless. Next slide. Listing here the different techniques that are available. Of course, RF thalamotomy has been around for many decades. DBS has now also been around for several decades. We'll probably hear a little bit about ultrasound for thalamotomy later on. There has been description of laser. We're going to talk a little bit about SRS thalamotomy. Again, you're targeting the ventral intermediate nucleus of the thalamus and targeting the dental-rubothalamic tract. So we'll talk a little bit in the end about how some people are using diffuse tensor imaging to really look at that particular tract in their targeting. Next slide. So it has, a list of advantages. I already talked about how one of the disadvantages is that it doesn't have an outcome as DBS for patients who's available to go through DBS. But some people aren't good surgical candidates. There's minimal risk with the patient on anticoagulation for the procedure, and the patient doesn't have to have surgery, they don't have to have anesthesia. And the other big disadvantage for SRS thalamotomy is you really can't see the target on typical MRI scans. Next slide. So it was helpful for myself when I was setting this up in 2013 here at Yale. These are 2 big series that are presented, one from Swedish and Dr. Young, one the senior author, the UPIT series in 2013. And this just shows the slightly different techniques they described, and you can do DBS, you can see how it's a little bit different from DBS. The big difference is you're targeting the center of the nucleus you want to affect, rather than in DBS you're targeting the ventral edge of the nucleus. Different techniques, they both typically use stir imaging in the coronal plane to really set the final target. One's a little more aggressive than the other, I found, depending on whether you use a 50% isodose line against the border of the thalamus versus a 20% isodose line off the nucleus of the internal capsule. What I found to be helpful is different centers. We have Siemens scanners. Most of this stuff is described with GE scanners. Our Siemens scanners are much better at T1 imaging than they are with T2 or IR imaging. So we get some really nice pre-procedure imaging as well as high resolution DTI. Next slide. Sorry. So if you use connectivity analysis, this picture is not showing up. Next slide. Next slide. Keep going. There you go. One more. So, it's becoming more common. Sorry, go back up one. Becoming more common to use DTI imaging. I use it to help locate the internal capsule. And some places argue that you can actually see the dental rubral tracts. And you can use that to help place your target. Next slide. Move on to obsessive compulsive disorder. As I talked about in the beginning, there's been stereotactic radiosurgery has been used for anterior capsulotomy for a couple decades. Very helpful in treating patients with obsessive compulsive disorders, which is another common anxiety disorder. It has a high level of prevalence. A significant number of patients that are medically refractory, and the therapy can be quite useful for them. Next slide. So the early experience Again, we're using very high doses here. You know, thalamotomy, we're talking 130 gray. Here we're talking 180 gray. Next slide. So this was efficacious. You can see there's 3 shots there covering a significant portion of the anterior capsule. And the next slide. The issue was that there was a lot of side effects. Patients had a lot of edema. There was disinhibition, and they had a lot of side effects from this particular treatment style. Next slide. So again, good efficacy, high side effects though. Next slide. So more recently, there's been published 2014 a series of patients that used a different technique, used a 2-shot technique, and this shows the responses here. This was blinded for a period of 1 year, and in that period they had 3 out of 8 responders versus 0 out of 8 in the sham group. Next slide. Next slide. That shows a decrease. Here's the response rate. And then this is the open label part and the total response when all patients were were in the therapy arm. Next slide. So over the course of time, what we've seen is instead of making 3 lesions, making it bigger lesions, and people tried 1 in the middle, didn't have very good efficacy. As you move more ventral, it tends to be more efficacious. And then, so you can see the technique reported by Brown, but they did still have some cysts and some symptomatic issues with the 2 shots. And what was noted is that it was the different models with the Gamma knife, and I'll show you in a second what that means. It means the shape of the shot is different. Next slide. So this is what I was talking about in that previous slide. If you do 2 shots, what happens in the shot on the right with model BC or perfection is the shape is wider and shorter. And so the 12 gray line crosses over the midline versus the picture on the left. So what you need to do with the newer models is use a multiple shot technique to take the shorter, wider ball and turn it into what you want, which is the thinner, taller ball. Next slide. And by doing that, you can have that 12 gray line not cross the midline. And this has been referred to as the 5-shot plan, where you use 5 shots on each side to give you a better contour along the anterior capsule without having the spread of the 12 gray line very far, and definitely keeping it from crossing the midline. Next slide. So this is a very highly conformal plan, and it ends up with a plan that you see on the right there. If you think about the total volume that's treated with 60 gray, it's smaller. So you get less necrosis, less likely to create cysts. But the trade-off, of course, is the treatment time. The first time this treatment was used, it took 6 hours for this treatment time. And interesting enough, after a cobalt-60 source reload, the next treatment time was down to 3 hours. There's been, I think, about 6 patients now done with this plan, and at least 4 have been responders. So it seems to be promising as we study more to give a good, efficacious outcome with minimized side effects from the procedure. Next slide. And then finally, I'd like to wrap up just with something that we published when we noticed that there was a difference in change in our outcomes with our thalamotomies. And it's important when we're doing functional radiosurgery, we're using really high doses. And so just even subtle changes in your sources can make a difference in your outcomes. And what we found when we did this study, when we looked at the difference in the biological equivalent dose that was given, is you can see that there could be changes in these doses that make a difference. And what happened with us was we didn't have any side effects, but we also suddenly our patients weren't getting this good therapy with the same dose. So it's important to recognize that over the time, if you're treating something with 130 gray, that every year about 3% of your biologically effective dose goes down. So if you're treating the end of your sources, you may want to consider increasing your treatment times or increasing the overall dose in order to get a similar biologically effective dose. And be aware of these things. Also be aware when you switch into new sources that you might need to be aware that you may be actually delivering a higher biological effective dose than you were in the previous year. And with that, I think I'll wrap up. Next slide. That's it. Yeah. Thanks everyone. Again, thanks to Samir Chef for helping me out with some of those slides for anterior capsulotomy.
So we'll take one question for Dr. Gerard while I pull up my slides. Okay, since we don't have any questions, I'll start my talk. Are you able to see the slides, everyone?
I see them.
Great. So we're going to be talking about focused ultrasound, and I wanted to discuss the existing applications and future of this technology in clinical neuroscience. And I realized that I was the last talk in the day. So, if you were to remember only one thing from this presentation, then these are these three major take-home points. So we'll be talking about what is focused ultrasound, can it be used to treat neurological disorders, and what is the future of focused ultrasound in neuroscience. And the answer to these questions is focused ultrasound is an awesome technology, and you can use it to treat neurological disorders. And the future of focused ultrasound in clinical neuroscience looks very bright. And so with that said, I'll just introduce the technology a bit. As Jason talked about the gamma knife, similar to gamma knife, focused ultrasound also involves having hemispherical arrays with ultrasound transducer elements organized in this hemisphere. And with the current commercially available transducer, you have 1,024 different elements that are organized in this helmet that goes on patient's head during treatment. And the energy on these ultrasound elements can be graded. So you start with smaller dose and then slowly increase it. Each one of these ultrasound deliveries is called sonications. So you could have low energy sonications followed by higher energy sonications. This technology is paired with MRI for two major purposes. One is to acquire live images so that you could do anatomical image to see how your lesion looks like when you're creating the focused ultrasound ablation. And the second one is to acquire thermography to really understand how much heat is the tissue that you are ablating is experiencing. And so thermography and anatomical imaging are provided in this technology through integration with MRI. Now, a lot of us wonder, what's the difference between the diagnostic ultrasound that we use in day-to-day, radiology diagnostics and focused ultrasound. So one of the main differences is the frequency of ultrasound that we use. The diagnostic ultrasounds are mainly in megahertz range, while the focused ultrasound for therapeutics are either 650 kilohertz, the system that's used for ablations, or 220 kilohertz, the system that's used for blood-brain barrier opening or neuromodulation. And this graph actually shows the tissue penetration with different frequencies, highlighting that with lower frequencies, the tissue penetration is higher. Now, when you think about the mechanism of ablation with these ultrasound frequencies, the 650 kilohertz achieves ablation through increasing temperature. So it's a thermal ablation. Micromovement from mechanical ultrasound waves results in increase in temperature of the targeted tissue. 220 kilohertz system, in addition, can also achieve ablation through what we call cavitation. What cavitation does is it causes the gas bubbles trapped inside mammalian tissues to start resonating and increase and decrease in size till they burst, resulting in ablation at the tissue level. One thing I want to point out here is that ablation through cavitation is not commercially available and has not been tested in humans just yet. It's a lab preclinical kind of work that people are working on trying to optimize for future clinical applications. The next aspect with focused ultrasound is water coupling. As you all remember, that for diagnostic ultrasound, you use the jelly to couple the ultrasound from the transducer to tissues. Same way for the ultrasound treatments, transcranial treatments, you need water source to couple the ultrasound from the transducer to travel through that medium to get into tissues, because the travel of ultrasound through air is not feasible. As you can imagine, that skull creates a major barrier for these transcranial ultrasound treatments. When people do the transcranial Dopplers for detecting vasospasm after subarachnoid hemorrhage, they're shining the ultrasound through the temporal windows, because shining the ultrasound through the rest of the skull doesn't really provide you a good estimate of the velocities inside the skull. And so for therapeutic ultrasound treatments, we do a CT scan of the head to really understand if someone's head is, or the skull is suitable for treatment. And this is done by calculating a metric called SDR, skull density ratio, that really captures whether the skull is homogeneous or heterogeneous. A skull density ratio of more than 0.4 signifies that the skull is homogeneous and therefore it is suitable for ultrasound treatment. Now, although ultrasounds were tested by Fry brothers in Chicago in 1950s and 60s, their application at that time required for removal of the skull. So craniotomies had to be done before ultrasound ablation could be achieved inside the brain. The major advantage, or the major innovation, I should say, that brought about the modern transcranial ultrasound treatment started with this idea of doing the electronic phase correction. So when the ultrasounds pass through skull, or any other tissue for that matter, there is a phase shift in the ultrasounds. And as you can imagine, that ultrasound beams in different phases could cancel each other out and therefore not be effective. And so therefore, in the modern ultrasound transducers, electronic phase correction by anticipating the phase shift and correcting for that is the key in achieving the coincidence of all the ultrasound beams in same phase at the target. Now, what neurological diseases can be treated? So in this cartoon, we have the mechanism of focused ultrasound for therapeutics and the different indications listed. The indications in blue are the ones where human application has been reported, and the red ones are the ones where preclinical work has been done. And so on the right-hand corner is the thermal ablation, which is the most common and most widely available ultrasound application. It's being tested in humans for essential tremor, Parkinson's disease, epilepsy, neuropathic pain, OCD, and the application for dystonia is in works. For targeted drug delivery through opening of blood-brain barrier has been tried in brain tumors and neurodegenerative disorders like Alzheimer's disease, and future applications may include stroke. Ultrasounds also produce neuromodulation just by mechanical excitation of the neural elements. And the human application of that was reported in a case report of treatment of a patient with coma using focused ultrasound. And the other applications are still in the preclinical and planning stages. And as I mentioned before, cavitation or histotripsy as a way of ablating tissue at the tissue level is still in preclinical application, has not been reported in human application yet. But the epilepsy and brain tumor applications are in the works for this. Now, for the existing indications, 2 FDA-approved indications for focused ultrasound ablation are essential tremor and tremor-dominant Parkinson's disease. Essential tremor was approved in 2016 and is being reimbursed now. Tremor-dominant Parkinson's disease was approved in 2019 and the reimbursement is pending. So I'll present the results of the pivotal trial that was done for the FDA approval for essential tremor. So it was a multi-center randomized sham-controlled trial that tested the safety and effectiveness of focused ultrasound ablation. And the target, as Jason described, is the ventral intermediate nucleus. 76 patients were randomized and divided into the treatment and the sham groups in 3:1 ratio. Sham patients crossed over after 3 months. And the primary efficacy endpoint was comparison of hand tremor on the treated side using a scale we commonly use in movement disorders called CRST. And the evaluations were done blinded. And as shown in this graph, in the sham group, there was no major change in their tremor scores, while in thalamotomy group, the tremor significantly reduced. And although there was some return of tremor at 1 year, patients still continued to have significant suppression in their tremor. Overall, when you look at the results at 3 months, there was 47% improvement in contralateral tremor, and a 40% improvement was sustained at 12 months. and patients reported improvement in their quality of life in different aspects of their day-to-day living. There were several adverse events that were reported, and they are broadly, if you look at them, they are on-target side effects and off-target side effects. And the most common ones are paresthesias, ataxia, weakness, and gait disturbance. If you look at the predictors of outcome after focused ultrasound, so younger age tends to be better prognosis, shorter duration of disease, number of sonications. If you're struggling in a treatment for more than 20 sonications, likely things are not going well. And then higher the temperature, the better results overall. And so during the treatment, these are the things that we are looking for to increase the temperature beyond 55 for a better outcome. Now, the pros and cons, some of these were discussed already during the stereotactic radiosurgery discussion, and so it's incisionless, immediate effects, no implanted hardware, no battery replacement, it's cost-effective treatment. Efficacy is poorer, as compared to DBS, we are not able to achieve that good of tremor control. The durability of outcomes is unknown. The risk of adverse events is there. You can only treat one side of the brain at a time. And then the cost of purchasing and maintenance of the equipment is very high. So this is the overall picture. Now, when I look at this treatment, the first iteration of this and the results that you've seen, and so I tend to look at it that there are several challenges that need to be addressed. And as we mentioned before, some of the side effects that are coming in are related to off-target side effects. And so we think that improving the visualization of anatomy with tractography can help avoid some of these off-target ablation side effects. And so we use tractography to really map out the pyramidal tract and the medial lemniscal fiber system, and then point and try to understand the anatomy relative to these tracts to localize VIM and target dentatorubral-thalamic tract, as Jason mentioned before. Now, the other aspect is, as you saw, that at 1 year, the tremor outcome, the tremor relief was slightly less than 3 months. And so loss of efficacy remains a concern. And the major factor that we think that's causing some of this is lack of objective intraoperative feedback. And we're working on ways to improve this by either using microstructural imaging to visualize the area of ablation and understand if we have partial ablation that may result in loss of efficacy later on, or even use fMRI to really get a feedback like we do for intraoperative physiology with deep brain stimulation. And so some of this tractography work we have published and shown that it can improve the safety and effectiveness of focused ultrasound. And we had evaluation of outcomes by the same tremor research group through a blinded assessment, and had more than 50% tremor reduction using prospective tractography-based targeting for focused ultrasound ablation. And then, as I mentioned, that during surgery, we have physiological feedback in DBS using microelectrode recordings. We are hoping that in the same way we could use fMRI-based feedback or looking at the changes after ablation at the site of lesioning to understand whether we have complete ablation or partial tissue ablation, and move towards creating more complete ablation for the tissues. What are the potential future applications? So Parkinson's disease, we are looking at pallidotomy in a phase 3 trial. Epilepsy, we have started a phase 1 trial, antenucleus thalamotomy. There is a trial of hypothalamic hamartoma ablation, and also there is a trial for neuropathic pain that is being looked at. The trial that we have started with antenucleus thalamotomy is recruiting patients that have disabling medication refractory epilepsy, which are partial onset with secondary generalizations, and we're looking at patients who have high seizure frequency. And so this trial is ongoing right now. In future, the 220 kilohertz system, as it becomes more prevalent and more available, then blood-brain barrier opening for indications like Alzheimer's disease and with wider treatment envelope for epilepsy and neuro-oncology applications, and as we discussed, the neuromodulation applications as well. You must have seen this publication about BBB opening in patients with Alzheimer's disease with the goal of removing the amyloid plaque. And so that work is currently underway in the United States. We have a phase 1 trial that's ongoing right now for this application. So at the end, I wanted to summarize, what is focused ultrasound. It's an emerging non-invasive treatment for a variety of neurological and psychiatric disorders. It's clinically approved for the treatment of ET and tremor-dominant Parkinson's disease. And we're looking at its application for Parkinson's disease and epilepsy. And future advances are underway to understand the mechanisms of its effectiveness and improve the safety and effectiveness using neuroimaging. These are my sources for funding, and thanks to all the folks who have worked hard in the lab, and I've used their work in this talk. So we'll take any questions. We are already 8 o'clock. I don't want to keep you long, but happy to answer questions if you have. So are there any questions? I couldn't hear. So it looks like we don't have any further questions. So thank you all for participating. And the video recording of this will be available soon as well. And thank you again.